Hello, I'm Mark Brewster. I'm a hand surgery consultant in Birmingham at the Royal Orthopaedic Hospital. And what we're going to run through is some general examination of the hands and then working through disease specific. First of all, your examination really starts when the patient enters the room. You want to introduce yourself primarily so you can feel their hand with the handshake and see if they are actually withdraw or they have trouble with handshakes. You want to be bare below the elbows for infection control purposes. And you're also assessing the patient's age and sex because many conditions are more common in different age groups and with male and female. You're assessing whether they've walked in, used a stick, or in a chair, have different splints, because not only will that determine how you interact with them and how they need to be walked around the hospital and aided, but also if you are considering surgery, then if you actually operate on the hand that they used to weight bear on, that needs longer to recover because it's a weight bearing joint, but also you may immobilize them effectively by stopping them use their walking aids. You would routinely work through your history of presenting complaints, your past medical history, social history, drug history and allergies, but specific to hand examinations, we tend to concentrate also on the hand dominance. That's important to the effects this problem is having on them. On their work, and not just whether they're a factory worker or whether they're admin worker, but some of the finer details of their work and therefore how their condition affects different aspects of their work. And their hobbies. Some people have hobbies that just take a bit of time, and some people have hobbies such as music they actually earn money from and a lot more important to them. Although we're going to look mainly at the hand, it is also important to review the neck and the shoulders, because not only can pain be referred from the neck and the shoulder down the arm, but also from a positional point of view, such as giving a patient a general anaesthetic, you need to know the flexibility or pain in the neck, and also from a position from putting a hand on an arm board or tables for surgery, you need to be aware whether you can actually get the hand in the appropriate position for that surgery. And then we really look through the steps you'll go through for each examination, which you'll probably do anywhere in the musculoskeletal system, which is the look, feel, move, and then special tests. So looking for the upper limb really starts at the elbows. So you're bare below the elbows for infection control purposes, but they need to be bare below the elbows so you can examine from the elbow down to the fingertips. First of all, you're best off flexing the elbows, and then you can see if there's any scars, any skin changes on the dorsum of the forearm and on the elbow. And then you have the palms up on the table, often on a pillow for comfort for the patients, especially if they have very tender hands such as in rheumatoid arthritis, and then the palms down. As you're working through, you're looking at all the different aspects of the hand and upper limb. So for the skin, you're looking potentially at different rashes, because they may be something like psoriasis that can be associated with inflammatory arthropathy, or may actually be right over where you're planning to do surgery, such as a poor skin due to eczema. You're also looking at depigmented areas. A number of the conditions we treat with steroid injections, and they can actually cause thinning of the fat, so lipoatrophy, and depigmentation, particularly things such as de Quervain's injections. You're also looking for other signs of their conditions affecting them. So on the hands, if you have nerve problems such as carpal tunnel or cubital tunnel, people sometimes have burns on their fingers because the sensation is poor. And also, one thing to look for in all patients with modern musculoskeletal is little punctate bleeding or bruises on the fingertips, because this can show that they're taking blood tests for diabetes, and it can be, if you've missed that in your history, a good way of spotting that they actually are diabetic. Working on into the nails, you can see sometimes pitting with psoriasis or nicotine staining, which can be important from your assessment of their condition and the potential for anaesthetics. Scars, which I'll go through more with each condition because they're specific to the conditions. But although you have the scars of elective surgery, you also have scars of trauma. So you need to know the anatomy around which that scar will affect, such as a transverse incision across the forearm may affect the median nerve, the ulnar nerve, and lots of the flexor tendons. But as I noted, I'll work through those work through each condition as we go. Lumps and bumps. There can be a number of lumps and bumps, from anything from rheumatoid nodules on the elbows or over the hand to ganglion, so fluid-filled sacs over joints, most commonly over the wrist. And with these, you also need to note which joint they're around and whether they're getting larger, smaller in your history. Also to note, although not really related to hands, is whether the patient has AV fistula. Because if you're planning to operate on the arm and they're a renal dialysis patient, you really need to be aware of these another lump such as that in the same arm that you want to operate on. Joint deformities and swelling, you need to know what the normal hand is like to see if there's any joint deformities and swelling. They're particularly common in rheumatoid arthritis, and I'll work through each of those as we go through the individual conditions. And then wasting of different muscle groups. Again, we compare both hands or forearms, and wasting can be due to nerve problems such as carpal tunnel or cubital tunnel syndrome, but also can be due to disuse. And you often find that in elderly patients, they do have quite marked wasting of their hands compared to a younger person. Finally, on the looking, you want to look at the attitude of the hand in a relaxed position. The attitude is the way the fingers sit and the thumb sits in a relaxed position. And what you'll see from my hand is the fingers are slightly more flexed towards the ulnar side. So if, for example, you have a claw hand, which we'll discuss in detail with cubital tunnel syndrome, the fingers are slightly more bent on the ring and little fingers from an ulnar nerve problem. You may have a slightly extended finger if the tendons are injured or the nerves to the motor of that tendon are injured, or maybe slightly more flexed fingers if you have a contracture due to Dupuytren's or trigger fingers. So when you move on to feel, you want to be comparing both hands and working along from proximal to distal. First thing you need to do, which you may have done in the examination already, is ask whether there's anywhere that's particularly painful for the patient so that you can be more careful when you're examining that area or that joint. So from a feeling, you can work with the back of your hand to feel over different joints to see if they're particularly warmer. You may even actually feel whether they're slightly boggy or have any crepitus over them. And also you need to be keeping an eye on the patient's face to make sure that you're not causing them any pain. To look at more individual joints, you can work through holding each joint, but we'll discuss that on rheumatoid arthritis. That's where you tend to really examine each specific joint rather than focusing on the patient's condition. When you're looking at lumps and bumps that you've found, this is the same as anywhere else in the body, where you look for the site, such as over the wrist, the size, the shape, the consistency, and whether they're tethered to the skin, so you can move the skin over any lump that you find, whether they're tethered to the tendons or structures underneath, which would involve the patient making a fist and seeing if the lump moves and then straightening the fingers. And then also, if it's a large lump that you think may be fluid filled, you can turn the lights on transluminate nets with a pen torch. That's rarely done in hand surgery because often the lumps are very superficial and clearly easy to diagnose. For a general overview of move for the hand, you want to look at each different joint and you want to work through active and passive. Obviously, if the patient has full active movement, so the patient can do all the movements themselves to the full range, you don't really need to work through passive because they've completed the movements. And you also need to be aware of how you would really define whether something has a fixed deformity or whether it has a lag. So a lag is the difference between active and passive, and therefore if I turn this hand up for you here, and if the patient can only straighten their finger to about there at the proximal interphalangeal joint, but then I can straighten it further, then the patient would have a lag of that extensor tendon, which would be the difference from about 45 degrees from there to there. Whereas if the patient trying to straighten that finger got to about 45 degrees, and when I tried to straighten it, it wouldn't go any further, that's likely to be a fixed flexion deformity because the joint or something anterior to the joint is stopping it move. Then working through each of the joints, we've already discussed that you would add on, if there's any concerns, examination of the neck and the shoulders, but working first of all from the elbows. For flexion extension, which is a range of usually 0 to around 145, although many people do have some hyperextension of their elbows, the best way to see it is for a patient to put their arms up, fully straighten their elbows out, and then try and touch their shoulders. Most people should be able to touch their shoulders, and that'll be around 145 degrees of flexion. Then, if you bring your hands down onto the table, you'll be looking at supination and pronation. Ideally, this needs to be done with the elbows at 90 degrees. So I can get you to shuffle forward very slightly, so your elbows are at 90. There we are. And then you want to turn your palms up, and then palms down to see supination and pronation of the forearm. It can sometimes be difficult to assess, so you can exaggerate it either by putting the thumbs up and turning out and then inwards, or by using a pencil or something longer, so the patient can grip this pencil and pen there, and then if you turn your palm down into pronation or across into supination. This exaggerates the movement if it's fairly limited. Okay. The normal movements of pronation and supination are around 70 pronation and 85 supination. Then you want to work on the wrist movements. So for flexion, if I can ask you to bring the back of your hands together and bend down. So you see from my point of view, most people will get around 85 to 90 degrees of flexion. And then if I can ask you to extend by bringing your elbows up as high as you can, you're looking for the range of movement of these, but also the symmetry between the two, if the patient has a problem with one rather than the other wrist. And again, that's around 60 to 70 degrees of extension. And then radial and ulnar deviation, they're best to do on the table. So if I can get you to keep your forearm straight and just turn your hand outwards and then inwards, you're assessing the radial and ulnar deviation. It's very difficult to keep your arm straight and do that because you're trying to do a bit more movement to exaggerate it. So as was the case here, there was some slight movement. So it's best if you, as the examiner, hold the forearm. And if I can get you to do that again, go into ulnar deviation and radial deviation. And if you're wanting to measure this accurately, you will draw a line down the middle of the forearm and then along the third metacarpal, and use a goniometer, which I'll look at in more detail with Dupotrons and how to use them and see what the angle is. Usually it's around 20 degrees radial deviation and 35 degrees ulnar deviation. Then we'll work onto the thumb. So if I can just turn your hand up there, and then we'll turn this one. So the thumb has a CMCJ at the bottom, carpal metacarpal joint, MCPJ, metacarpophalangeal joint, and IPJ. So there's only two phalanges, so it only has an interphalangeal joint rather than a proximal and distal interphalangeal joint. At the CMCJ, there's two main movements. There's flexion and extension, so the thumb comes down into the palm and then out. It can also be called radial or ulnar adduction, which can get confusing. And then there's abduction and adduction, whereas adduction is bringing the thumb against the palm and adduction is pointing the thumb up to the sky there. Usually it's considered that contact or zero is where you start with the adduction, around 45 degrees with the abduction. It's sometimes very difficult for patients to actually do that, so it's easier to actually put, if it's not painful, to put their thumb in that position if you're going to examine the range of movement. There is another combined movement which is opposition, which combination of abduction, flexion and some pronation. And it's very difficult to measure angles, and therefore a grading score has been used to assess this. So if you want to follow what I do with my hand there to assess it, so 1 is to touch against the side of your index in the second phalanx. 2 is to touch to the side of it, but not on the tip. 3 is to the tip. 4 is to the middle fingertip. 5 to the ring fingertip. 6 to the little fingertip, and then you work down the creases to 7, 8, 9, and then 10. And that's a Kapandji score. So someone can go directly to there, and they've got a normal range of movement. However, a lot of people, even in their normal range, can only get to 9. You need to compare with the other side. The MCPJ tends to have a range of movement of about 0 to 60 degrees, but that's very variable. And certain conditions, as we'll discuss, have a lot of hyperextension. It's sometimes difficult without supporting the hand to assess the difference here, because if you try and bring your thumb over to here, you see that there's movement of the metacarpal and the phalanges. So it's best if you want to examine the MCPJ to stabilise the metacarpal first, and then ask the patient to bring the thumb over there to get the angle up the back of the metacarpal and across. Similarly with the IPJ to support the next joint, and then if you can just bend the tip of your thumb. The flexion and extension at the IPJ of the thumb is usually from around 0 to 80, but again, some people have fairly marked hyperextension at those joints. There's quite a lot of variation in how much hyperextension people have due to their flexibility. Then working towards the fingers, if I can get you to put your palms down. So most people will start off straight in the relaxed position if they put their fingers out, but they have quite a marked amount of hyperextension that you can achieve. And therefore you can lift, as long as it's not painful, each individual finger. And most people will get to around 45 degrees hyperextension at the MCPJs, although some people will get to almost 90 degrees at the MCPJs of the little finger. The MCPJs will then flex, if you can ask you to make a fist, to around 80 to 90 degrees, which you can see usually from the side. Again, while you've got that this flexed, you can see the flexion of the PIPJ and the DIPJ, which is to around 100 degrees at the PIPJ and 80 to 90 at the DIPJ. Now, if you can ask you to straighten your fingers fully, most of the people will have 0 as their position of their PIPJ and DIPJ, but around 10 degrees of hyperextension at the PIPJ and up to 45 degrees or even more is normal at the DIPJs. Obviously, if it's not symptomatic and it's equal on both sides, it's normal for them.